Welcome to our first video on diseases of the esophagus. Let's begin. In this lecture, we'll discuss esophageal cancer and achalasia. For esophageal cancer, we'll discuss definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management. Esophageal cancer can be either adenocarcinoma or squamous cell carcinoma. Adenocarcinoma is more common in the United States and usually affects the lower third of the esophagus. In contrast, squamous cell carcinoma is more common worldwide, and it typically affects the proximal two-thirds of the esophagus. Risk factors for adenocarcinoma are related to chronic acid reflux in the esophagus. Gastroesophageal reflux disease and Barrett esophagus are the two strongest risk factors for esophageal adenocarcinoma. We'll talk about GERD in detail later in this lecture. Barrett esophagus is the intestinal metaplasia of the distal esophageal epithelium, mainly due to chronic GERD. Persistent Barrett esophagus can progress to adenocarcinoma. Obesity increases the risk for GERD and Barrett esophagus. Therefore, it also predisposes the patient to adenocarcinoma. Smoking is another well-established risk factor for esophageal adenocarcinoma. Now let's discuss the risk factors of esophageal squamous cell carcinoma. The two strongest risk factors for squamous cell carcinoma include smoking and chronic alcohol intake. Both tobacco smoking and alcohol induce dysplasia of esophageal epithelium. Plummer-Vinson syndrome is characterized by esophageal webs and abnormal esophageal epithelium, predisposing to squamous cell carcinoma. Hot liquids and caustic ingestion can also cause epithelial scarring and dysplasia in the esophagus. Finally, achalasia causes chronic mucosal irritation by retained food, leading to dysplasia. We'll talk about achalasia in detail later in this lecture. In general, the pathophysiology of both types of esophageal cancer includes some sort of irritant stimulus which induces metaplasia or dysplasia of esophageal epithelium. Later, metaplastic or dysplastic epithelium undergoes an irreversible malignant transformation resulting in cancer. Esophageal cancer may present with nonspecific symptoms such as weight loss, fatigue, and low-grade fever. Additionally, it is characterized by progressive dysphagia. Progressive dysphagia is difficult swallowing solid food, followed later by difficulty swallowing fluids as well. This is due to an enlarging mass obstructing the esophageal lumen. Odynophagia, that is painful swallowing, and chest pain can also occur. Patients may present with hoarseness if esophageal cancer invades the recurrent laryngeal nerve. Esophageal cancer is characterized by rapid spread because esophageal wall does not have serosa that would contain the cancer cells within the esophageal wall. Therefore, esophageal cancer has poor prognosis because it typically presents at an advanced age. A 67-year-old man comes to the physician due to 20 kilograms unintentional weight loss over the past 4 months, low-grade fever, and progressive dysphagia. He's been smoking 2 packs of cigarettes per day for 40 years. He's been drinking 1 bottle of wine daily for the last 10 years. Recently, he noticed hoarseness of his voice. He is diagnosed with esophageal squamous cell carcinoma. What is the most likely underlying cause of this patient's hoarseness? The patient with long-term smoking and drinking history has 20 kilograms of unintentional weight loss over the past 4 months, low-grade fever, and progressive dysphagia. Recently, he noticed hoarseness of his voice. He is diagnosed with esophageal squamous cell carcinoma. Hoarseness in the context of esophageal cancer is best explained by recurrent laryngeal nerve invasion by malignancy. Definitive diagnosis of esophageal cancer is made by endoscopy with obtaining biopsy. Endoscopy may show either exophytic, that is protruding, or endophytic, that is ulcerating, mass in the esophagus. Biopsy specimen of adenocarcinoma will reveal mucin-positive cells arranged in tubules. In contrast, the biopsy specimen of squamous cell carcinoma will show keratin pearls and intracellular bridges, which are desmosomes. This is how esophageal adenocarcinoma looks like on endoscopy. Please note this exophytic mass, which represents the esophageal cancer. This is how esophageal adenocarcinoma looks like under light microscopy. Please note these metaplastic tubules. Here we see the biopsy specimen from the well-differentiated esophageal squamous cell carcinoma. We can appreciate this keratin pearl. Additionally, the patient diagnosed with esophageal cancer should undergo a full metastatic workup. Transesophageal ultrasound may detect local mediastinal metastasis. CT of the abdomen and pelvis may reveal distant visceral metastasis. Finally, bone scan may show possible bone metastasis. Management of esophageal cancer may include chemotherapy such as cisplatin 5-fluorouracil and paclitaxel. Radiation therapy or esophagectomy, can also be performed depending on the cancer stage and the patient's comorbidities and preferences. Finally, hospice care is typically established for patients with advanced stage disease. A 78-year-old woman with a 20-year history of gastroesophageal reflux disease presents with unintentional weight loss, low-grade fever, and progressive dysphagia. Endoscopy shows an exophytic esophageal mass. Biopsy confirms esophageal adenocarcinoma. What is most likely seen on the biopsy of this patient's lesion? This patient with long-term history of gastroesophageal reflux disease presents with unintentional weight loss, low-grade fever, and progressive dysphagia. Biopsy of an exophytic esophageal mass confirms adenocarcinoma. Biopsy of adenocarcinoma typically shows mucin-positive, light-colored cells arranged in tubules. Now let's talk about achalasia. We'll discuss definition, causes, pathophysiology, clinical presentation, diagnosis, and management of achalasia. Achalasia is characterized by the failure of the lower esophageal sphincter to relax. This condition is mostly idiopathic. Let's talk about causes. The primary achalasia is mostly idiopathic. In contrast, secondary achalasia can be caused by Chagas disease due to Trypanosoma cruzi. This protozoan infects the esophageal wall and destroys the myenteric plexus. Esophageal cancer itself can cause achalasia by narrowing the lower esophageal lumen. Extraesophageal malignancies, such as mediastinal cancer, can exert the mass effect and externally compress the lower esophagus, causing achalasia. Achalasia is caused by destruction of inhibitory neurons in the myenteric, also known as Auerbach plexus. These inhibitory neurons release nitric oxide and the vasoactive intestinal peptide, which normally relax the lower esophageal sphincter. Decreased nitric oxide and vasoactive intestinal peptide levels result in decreased relaxation of the lower esophageal sphincter, leading to achalasia. Achalasia presents with dysphagia to both solids and liquids because this disease impairs esophageal peristalsis. Therefore, any food or liquid has difficulty going from the oropharynx down to the stomach. Since food is retained in the lower esophageal segment, the patient may have regurgitation of food while lying supine. Halitosis, which is the unpleasant smell in the oral cavity, can result from degradation of food particles in the lower esophagus. Finally, as we already mentioned before, achalasia increases the risk for esophageal cancer because retained food irritates the esophageal mucosa, inducing dysplastic changes. Let's talk about the diagnosis of achalasia. Barium swallow will show the characteristic bird's beak appearance due to distal esophageal narrowing. Esophageal manometry, on the other hand, will reveal weak peristalsis throughout the esophagus and increased lower esophageal sphincter pressure. Here we see the barium swallow image showing achalasia. We can appreciate the bird's beak appearance due to narrowing of the distal esophagus. Here we see the normal esophageal manometry findings compared to those of achalasia. We can see that the peristaltic waves are weaker and lower in amplitude throughout the esophagus in case of achalasia. Additionally, the baseline pressure of lower esophageal sphincter is increased. The chest X-ray in the context of achalasia typically shows widened mediastinum and absent gastric air bubble. Endoscopy with obtaining biopsy, on the other hand, can be performed to rule out esophageal cancer as the cause of achalasia. Here's a chest X-ray of the patient with achalasia. Please note the widened mediastinum indicated by the black arrows as well as the absent gastric air bubble. Let's discuss the management of achalasia. Pneumatic dilation is the procedure which uses air pressure to dilate the lower esophageal sphincter. It is a temporary measure because after some time, the lower esophageal sphincter pressure will rise again. Additionally, pneumatic dilation carries a risk for esophageal perforation. Another treatment option is the injection of botulinum toxin or Botox into the lower esophageal sphincter. Botulinum toxin inhibits acetylcholine release from the presynaptic terminals and therefore relaxes the lower esophageal sphincter. Similar to pneumatic dilation, Botox injection is also a temporary measure because after some time, the lower esophageal sphincter will rise again. Definitive treatment of achalasia is Heller myotomy. This is when the lower esophageal sphincter muscle is incised, relieving the obstruction. However, excessive drop in the lower esophageal sphincter pressure can result in GERD due to gastric acid reflux. A 45-year-old man presents to the office with unpleasant taste in his mouth and dysphagia to solids and liquids. He has occasional regurgitation of undigested food at night. Barium studies show proximal widening and distal narrowing of esophagus. Esophageal manometry is performed. What are expected findings on esophageal manometry? This patient presents with unpleasant taste in the mouth, dysphagia to solids and liquids, and occasional regurgitation of undigested food at night. Barium studies show proximal widening and distal narrowing of esophagus. All these findings are consistent with the diagnosis of achalasia. Esophageal manometry in case of achalasia shows weak peristalsis throughout the esophagus and an increased baseline pressure of lower esophageal sphincter. And that concludes the section.